Hi everybody, welcome to part 4 of common adult electrocardiographs. This Learnshop, as with the previous ones, are for all nurses and healthcare providers who monitor adult cardiac rhythms. And in doing so, we'll be assessing common and uncommon adult ECG arrhythmias and dysrhythmias. The objectives for part 4 are to look at what acute coronary syndromes are, look at angina really in this context of non-STEMI and STEMI, non-STEMI being non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction, and review it with certain ECG scenarios. So let's do the knowledge review again. Which of the following is the normal pacemaker of the heart? A, B, C or D? The answer is A, the SA node. Which of the following statements represents the P wave? A, B, C or D? The correct answer is atrial depolarization, D. Which of the following statements relates to the sympathetic nervous system? A, B, C or D? The correct answer is all of the above again. Which of the following statements is correct about normal heart rates? A, B, C or D? The correct answer is 60 to 100 beats per minute for an adult. With the parasympathetic nervous system, which of the following relates to it? A, B, C or D? The correct answer is all of the above. Which of the following pertain to standard ECG leads? A, B, C or D? The correct answer is all of the above. Which of the following pertains to sinus tachycardia? Is it A, B, C or none of them? The correct answer is it's got nothing to do with them. None of them relate to sinus tachycardia. 9. Which of the following connect to atrial fibrillation? A, B, C or D? The correct answer is all of them. Which of the following relate to premature ventricular ectopics? A, B, C or D? The answer is D, all of the above. What's the anomaly in this ECG rhythm strip? The anomaly is premature ventricular complexes, and these are couplet PVCs. What's this ECG anomaly? Very fast. This is supraventricular tachycardia. What about this bizarre rhythm? This is coarse ventricular fibrillation. How about this ECG anomaly? This is asystole. What about this final one? This is atrial fibrillation with a controlled ventricular response. Now let's look at the acute coronary syndromes. And the acute coronary syndromes basically are angina pectoris, non-ST segment elevation myocardial infarction, and ST segment elevation myocardial infarction, and we can throw in there Q wave myocardial infarction as well, which is old terminology and not typically used that often anymore, but still I think is relevant. And when we look at it, we must look at ischemia, injury and infarction, the three I's. The three I's that relate to the acute coronary syndromes. When we look at coronary syndromes, we have to look at coronary atherosclerosis, which can result in coronary arteriosclerosis, which basically gives us unstable angina, non-STEMI, ST segment elevation myocardial infarction. And this is all related to blockages that occur in the coronary arterial circulation. And it's acute because it occurs suddenly. And there's a specific pattern that's related to it, which relates to atherosclerosis. These are the typical evolutionary stages which relate now to the ECG changes. You've got the normal QRS complex, and then remember it's the QRS complex, ventricular, depolarization and repolarization that will be affected. So if there's a subacute partial coronary arterial occlusion, you'll get a non-STEMI. And I've just put it here to give it a picture. So the non-STEMI T-wave inversion, you've got there a little bit of a bump, negative deflection, 1 millimetre below the isoelectric line. This can get worse. This can get worse 2 millimetres, and even 3 millimetres, 4 millimetres, 5 millimetres, 6 millimetres below the isoelectric line. T-wave inversion, which can be asymmetrical or it can be symmetrical. Depends on the picture. When you've got complete coronary occlusion, this results in STEMI, which is ST segment elevation myocardial infarction, which can be more than 1 millimetre, 2 millimetres, 3, 4, 5, 6, 7 millimetres above the isoelectric line. And this also has T-wave inversion. When you start getting Q-wave development, as you can see there, there's a big pathological Q there, and typically a pathological Q, which I haven't mentioned previously here, but I will mention now, is wider than 0.1, is wider than 0.4 or one small square, deeper than 4 millimetres below the isoelectric line, or more than 1/3 or a quarter of the following R wave. And as you can see, that Q wave is pathological. But a Q wave represents irreversible myocardial necrosis. These are the typical evolutionary stages. When we look at non-STEMI, we're talking about ST segment depression. That's a normal ECG that you can see. Look at the ST segment, it's isoelectric. When it's pathological, it's depressed. And this one's depressed by more than 3 millimetres, nearly 4 millimetres below the isoelectric line. This is potentially pathological. And on your 12-lead ECG, which you need to confirm diagnosis, we can see you've got ST segment depression in most of the leads. This is an example of non-STEMI. When we look at STEMI, look at the normal ECG. We're looking at the ST segment elevation. So there it's isoelectric. Here there's elevation. And you've now got 1, 2, 3, 4, 5, 6, 7, 8 millimetres above the isoelectric line. This is ST segment elevation. And you can see on the ECG, you've got ST segment elevation in most of the leads. This is your 12-lead ECG. So let's revise. This is a 25-year-old male complaining of palpitations. What's the problem? Well, this is sinus rhythm with couplet PVCs. Then you've got a 32-year-old male who's asleep in the observation ward. What's the rhythm? This is sinus rhythm. Now you've got an 18-year-old female receiving bronchodilator therapy for asthma. It's regular. The rate's about 150. Seems to have a normal PKOST complex. This is sinus tachycardia. You've got a 49-year-old male receiving conscious sedation in a clinic. Maybe saturations are low. When you look at the rhythm, this is sinus rhythm with unifocal PVCs. Then you've got a 24-year-old male asleep in the post-treatment clinic with an irregular rhythm. And the irregular rhythm is a sinus arrhythmia. 21-year-old female having an acute anxiety attack must be a sinus tachycardia. Then you've got a 56-year-old male with acute moderate central heavy chest pain. He's demonstrating the Levine sign with his hand there on the centre of his chest, which indicates that he's got a cardiac problem. There's a sinus tachycardia with a non-ST segment elevation myocardial infarction, ST depression. Very clear. You've got a 56-year-old male with acute severe central squeezing chest pain, demonstrated by another version of Levine's sign with a closed fist. This is now sinus tachycardia with ST segment elevation myocardial infarction, STEMI. That's the end of part 4. To conclude, I think you should go and look at part 5, which presents uncommon ECGs in adults. Thank you very much, and see you again, I hope.